Welcome to this series of lectures in oral medicine, this one entitled Potentially Malignant Disorders. So the intended learning outcomes for this exercise will be that you need to know the different histological patterns between normal immune inflammatory and dysplastic neoplastic mucosa, which you'll recall from some of your SDLs in third year. Know the different types of special tests available for definitive diagnosis of these mucosal disorders, know how to carry out initial management of an at-risk lesion, and then know when to refer, and understand management of OMSCC, oral mucosal squamous cell carcinoma, including post-operative care as a general dentist. If we go back to your knowledge of the structure of normal oral mucosa, as you can see in this photomicrograph, where you have a section through a piece of epithelium showing keratinization at the surface with the epithelial cells going down to the basement membrane, followed by the underlying connective tissue. And if you look at this as a picture, you can see that this is generally fairly uniform in structure and color, and this is what you would expect to see in a normal oral mucosa. And there's no inflammatory mediation occurring in the subepithelial layer either. When we then talk about dysplasia, there is a lot of discord between pathologists because when we talk about mild, moderate, and severe dysplasia, where mild dysplasia is suggested to be in the bottom third of the epithelium, changes in that bottom third. If the changes occur into the 2/3 of the epithelium, it's moderate, and if it's the full thickness, it's called severe dysplasia and or carcinoma in situ. Now, there's no magical lines that are drawn that allow someone to say if it's mild, moderate, or severe. Therefore, you're going to get some inter-pathologist operator variation. When the dysplastic lesion then invades the underlying connective tissue, that's when we call it a squamous cell carcinoma. Thresholds tend to be also lower in these dysplastic lesions in the high-risk site, and that's probably why those sites are higher in risk. And the significance of the presence of candida in some of these lesions is also disputed or controversial. So here, when we compare this lesion to what you saw in the normal oral mucosa, you can see that there is disruption to the normal architecture. There's color variation, even though this is in black and white. There's some inflammatory response underneath. So this obviously has undergone some dysplastic change, the degree of which is something that you need to look closely to work out, but there's no actual invasion at this stage. So this is a dysplastic lesion, and these are the list of features of dysplasia that you remember from your SDLs in third year. And here you see in this lesion, the dysplasia has become a little bit more, and you're starting to get those drop-shaped Ricci ridges. And when they drop off and invade the underlying connective tissue, that's when it becomes a squamous cell carcinoma. So here are some of these features. You see some increased normal and abnormal mitosis. Here's an abnormal mitotic figure where the nuclei looks like a stellopad. Here you've got an increased nucleus cytoplasmic ratio in this cell. And here you see a loss of cellular adhesion or cohesion. Whereas when you compare that to this slide or photomicrograph, you see islands of epithelium that have drifted away from the epithelium, the surface epithelium, and this is frank invasion, and this is why we would then call this a squamous cell carcinoma. If you compare this to an immune mediated or inflammatory, again, you have got an inflammatory or immune response to what's going on in the epithelium, but the epithelial cells are a lot more uniform. Even though they're disrupted, you don't see those abnormal mitoses. There may be some cell death that's seen here, and there's a hyperkeratosis, but again, the changes are moderate and not dysplastic. So this would be an immune type. So if you can remember the pattern between the normal to the dysplastic, neoplastic to the immune or inflammatory, then those pattern changes that you see, just put that into your mind, try and recognize that, because that technique of recognizing pattern differences in histopathology is something that you can also utilize in the clinical situation, where you can look at the difference between a normal and a diseased mucosa. However, it's difficult to distinguish between an inflammatory, sometimes an inflammatory lesion, and or a neoplastic lesion just by the naked eye, unless it's an advanced lesion. So you will note that you will have some an assignment on Moodle site, which I would like the whole class to undertake, and I'll be monitoring each person's contribution to this, and this forms part of your back to base assignment to complete the task of learning about potentially malignant disorders. So if we now look at some of the biopsy techniques available for you to be able to distinguish between the different headings you might have in your differential diagnosis of say, a white lesion or a red lesion, or a neoplastic, or an ulcer. So some of the things in oral medicine to look when we're looking at mucosal lesions that are available: a swab, a smear, incisional excisional biopsy. An incisional biopsy where you take only part of the lesion, whereas an excisional biopsy is done where you've got a small enough lesion that you might as well take the whole lesion. Fine needle aspirate or core biopsy. Initially, if we look at some of the cytological examinations that we can do, you can do a swab. A swab is more probably useful if you're trying to do type of bacteria in an infection. So you might swab the pus and send that away for analysis so that you can work out what specific type of bacteria we're dealing with, and then you are able to utilize that for your decision to work out which antibiotic you're going to use. If you use a swab for candida to work out whether there's a candidosis, you may find that there is candida, but that's not going to tell you whether or not there's a candidal infection. Don't forget that over 40% of the population naturally have candida as a normal oral commensal. So it's only when they undergo hyphal change that they become infective. So a smear is much better in that regard, where you scrape the surface, smear it on a glass slide, and then stain it with some PAS stain, which will then stain the candida a magenta color. And if you see these hyphae, that's an indication that there's a candidal infection going on. You can do an imprint where you get a foam and put it on the area in question, then put it back on the culture, and then you culture that in the lab and to find out whether there's any candida growing. Or an oral rinse where you use a buffered saline solution to swill around the mouth and then spit back into the receptacle, and then that is used to look at possibility of presence of candida. But the problem here is the presence of candida doesn't necessarily mean there's an infection. And also in this technique, it's not site specific as well. Fine needle core biopsies, where you get a wide bore needle, for example, if you've got a swelling deep in the submandibular region where access for biopsy is difficult, and you want to find out, is it a normal or reactive swelling, or is it a neoplastic? You may put a wide bore needle in there, jiggle it around, and any tissue that comes out in the needle can then be examined as a gross way of looking at to see whether there's any neoplastic cells there. A fine needle aspirate biopsy is using a 22 gauge needle to aspirate fluid, for example, from a keratocyst where the fluid, examining the fluid might indicate there's a high level of protein, which can help with your diagnosis. The brush biopsy is where you use a cyto brush to reach deeper layers of the epithelium compared to a smear, and then you evaluate the cells using computer-assisted image analysis. However, this is time-consuming, and the high cost and false negatives make it perhaps less viable. And like I always keep saying, use the special test to confirm your differential diagnoses rather than using them to make the diagnosis. So here's, in this example, this patient had a swelling submandibularly, so we sterilize the area outside the skin, we penetrate into that swelling area, jiggle this needle around, then we put a little droplet on these slides where then they're smeared and then stained, and you can look at it under the microscope. And any that's left over we might put into this medium, which is centrifuged, so you get a solid mass which can then be embedded in some paraffin wax, sliced, stained, and further examined. We're going to now look at the incisional biopsy technique that I utilize. So here what we've got is an area of, it's not that clear on this photograph, but white change, where we will locally put some local anesthetic into the area. Then I will insert a suture anterior to the lesion, cut that off, and use a pair of mosquito forceps to retract and make that tissue area that I'm going to biopsy taut, and also gives me control. Then I'll use the scalpel to make an elliptical area and take the biopsy. And this allows me to control that biopsy, the tissue, biopsy tissue, without actually crushing it as you would if you were using a pair of toothed forceps. Then you suture the area up and you get reasonably good control. And a lot of this stuff I'm doing without suction. We can control the bleeding reasonably easy with just gauze. Don't forget that mucosal lesions that we talk about, white, red lesions or ulcers, are only dealing with the epithelium. The pathology is in the epithelium, so we don't need to go too deep with these lesions. So that biopsy specimen is then split into two if we're thinking that it's an autoimmune problem, and then one small segment might be put into some normal saline and sent for direct immunofluorescence, and the other one is put into some formalin, and that will be sent to the lab. You write the appropriate information on the pathology sheet, and then you number the pottles in the appropriate manner. So basically you take a biopsy, you send it to the lab where they embed it in paraffin wax, do the staining, you look at it on the microscope, and usually with hematoxylin eosin staining, which stains things pink and purple, that allows us to contrast between the tissue that we're looking at, and so we're looking at here epithelium and the underlying connective tissue. So hopefully that's given you an indication of what to look for when you're looking at epithelial lesions, whether they be red lesions, white lesions, ulcers, especially in high-risk sites, to learn how to do some further special tests, and then once you've identified an at-risk lesion, work out how you're going to manage that. And when you do your wiki case that I've assigned to the class, I'm hoping that you'll be able to further develop this to a working situation where you can use that as a reference for your exams and or when you graduate. Thank you.